One, we are live.
Thank you. A very good evening to all of you. I, on behalf of the Indian Society of Cornea and Cataract Refractive Surgeons, welcome you all in this wonderful webinar on guidelines on medical format for employment, the ophthalmologist perspective. This is a topic about which many of us are not very sure about, and it will be a wonderful idea to have the opinion of the experts in this direction. We have with us the president of ISCRS, Professor J.S. Titial, who is the chief and professor of ophthalmology at RP Center, AIMS. He is known for his publications, for his surgeries, huge experience in the field of cornea refractive, has received many awards, numerous orations all over the country, the first Indian to have performed the live cataract surgery at ASCRS, and the most coveted Padma Shri from Government of India by the President of India, and of course, teacher of teachers, Professor J.S. Titial. We welcome him.
We have with us Dr. Rishi Mohan, who's the Vice President of the ISCRS with us today. It is always a pleasure and honor to introduce him and to have him here at this platform. He's passed out from RP Center. As we all know, he has huge academic awards to his credit, including the gold medal and the certificate of merit, as well as the Resident Award, Best Resident Award at RP Center. And more importantly, he's held many leadership positions, which include positions at Delhi Ophthalmological Society. He was the Joint Secretary of Delhi Ophthalmological Society, the past President of Delhi Ophthalmological Society, has played a very important role in making the constitution of Delhi Ophthalmological Society. Apart from this, he's been member Scientific Committee AIOS, as well as for two terms, and member managing committee of AIOS. He's been the joint secretary of iBank Association of India and also the treasurer of iBank Association of India. And we welcome you, Dr. Rishi Mohan, today. I think we can skip this.
We also have with us Professor Namrata Sharma, who is the chairperson, Scientific Committee of ISCRS and Professor of Ophthalmology in the Cornea, Cataract and Refractive Surgery Services at RP Center. She is also the Secretary of AIOS, Regional Secretary, Asia Pacific Academy of Ophthalmology, Secretary of the Association of India, and has loads of publications to her credit, numerous publications, more than 500, many chapters, textbooks, and various publications, and has done various instruction courses all over the world. And it is a pleasure to have her as a co-moderator in this webinar.
Thank you, Rajesh. It is always a pleasure and honor to introduce our Professor Radhika Tandon, who's the Professor of Ophthalmology at Cataract, Cornea and Refractive Surgery Services at RP Center, AIMS, New Delhi. She has numerous awards of international and national acclaim to her credit, graduate and postgraduate from the All India Institute of Medical Sciences, qualified as Fellow of the Royal College of Ophthalmologists in London, as well as Fellow of Royal College of Surgeons, Edinburgh in 1992, elected member of the Indian National Academy of Sciences from Allahabad, also has done her Commonwealth Fellowship in United Kingdom, chairperson of the National iBank All India Institute of Medical Sciences, chairperson of Low Vision Services at RP Center, and immediate past president of iBank Association of India. There is a huge list of honors and awards which can be seen, which include the President of India's Silver Medal, Gold Medal by Royal College of Surgeons, Edinburgh, Best Case Presentation, and numerous awards by the Delhi Ophthalmological Society, International Who's Who of Professional and Business Women, examiner for the final FRCS examination by Royal College of Surgeons, Edinburgh, for the last many years, as well as FRCS examination ophthalmology in Edinburgh, in India as well, for Edinburgh in India as well, in 2001, 2002, and 2003, and has done huge amount of work in keratoprosthesis, ocular surface disease, as well as cornea, eye banking, and has been the torchbearer of our stem cell culture department at RP Center, and also has done this from Moorfields Eye Hospital, London, Sussex Eye Hospital, Britain, UK Transplant Service and Cornea Bank, Bristol, and Queen Victoria Hospital, from East Grinstead. So it is a pleasure and honor. Welcome Dr. Radhika Tandon to this webinar.
We also have with us Dr. Sulata Bhandari, who is the professor and head of the Department of Ophthalmology at Kasturba Medical College, Manipal, Mahe, Manipal. She has done her education from Manipal, and she has been instrumental in organizing postgraduate update programs at the Manipal Hospital. And she trains about 250 undergraduates every year, more than 160 postgraduates, and has 10 PhD scholars have got trained under her. Her area of interest is cataract and vitreoretina and ROP. She is co-director of a company called Vyabja Ocular Innovations Private Limited, of big BIRAC grant on ocular nanoparticle drug delivery system. Her area of interest is nanotechnology drug delivery system and retinal imaging. She has 60 publications, many awards, which includes the Distinguished Alumni Award and the Rajyotsav Award from Udupi Lions Club GSB Sadik Award. And of course, she is a member of many societies, and she has held various positions in various organizations. And she has also been the ex-deputy director, Student Affairs, Mahe, Manipal. And she's extremely inclined towards academics. And it's a great pleasure to have her in this webinar.
It is a pleasure again to welcome Dr. Kierti Singh, whom I know since my undergraduate days from Lady Hardinge Medical College. She's professor of ophthalmology and director of Guru Nanak Eye Center, New Delhi. Completed her post-graduation from RP Center, AIIMS. As well as did her senior residency from the same institution. She's faculty in the Glaucoma Division, Department of Ophthalmology, MAMC for last 19 years, recipient of the AIOS Young Ophthalmologist Scholarship in 1999, Commonwealth Fellowship in 2000, got her FRCS degree in 2000, WHO Scholarship in 2010, has authored 3 books, contributed to 18 textbook chapters with more than 55 publications in indexed and non-indexed journals, and over 350 lectures at state, national, and international conferences. She's also the honorary faculty of the Occupational and Environmental Health, and she also compares for national radio, television in promoting health awareness, and published a book on an anthology of poems. And what is not written here is that she's a very good writer, a good orator, a great teacher, and has trained many students under her. So we look forward to your lecture today.
It's also a great pleasure of mine, in particular, to welcome Dr. Chandna Chakravarti, who was my senior at RP Center, now currently associate professor attached to Ophthalmology Unit at RIO Calcutta. She is author of Sure Success in Ophthalmology, Viva OC and Practical Examination, a book for MD students, for MBBS students. She has 65 publications in various journals. She has worked as journal editor as a member of editorial board in IGO. She has been editor of Indian Journal of Community Ophthalmology. She has been editor of Bengal Ophthalmic Journal, associate editor of Equine Journal, editor journal of Equine since 2019, assistant editor. Again, she was in Equine Journal earlier. And she is into reviewer panel of many national and international journals. She has received various awards, which includes the recipient of AIOC 2021 Best Physical Poster Award in Trauma Session, recipient of Srimati Satyarani Hazra Memorial Award by West Bengal Ophthalmic Society, received Anadi Bhushan Memorial Award for Best Poster at OSWB again, and received J.C. Khanra Award for teaching by Equine. We welcome Dr. Chandna Chakravarti in this webinar.
It is a pleasure to welcome Dr. Satinder Singh, Professor of Physiology from University College of Medical Sciences in GTB Hospital, Delhi. He's won National Award by the President of India for Disability Activist, especially for his sustained efforts in making public places accessible for disabled persons. He was the first Indian to be awarded the McLean Center for Clinical Medical Ethics Fellowship at the University of Chicago. He was given State Award by Delhi Election Commission on National Voters Day 2020 on contributing to make the general elections 2019 inclusive and accessible. The Bucksbaum Institute International Scholar 2019 at the Bucksbaum Institute for Clinical Excellence at University of Chicago. McLean Center for Clinical Medical Ethics Fellowship from University of Chicago in 2019. Then he's also been given the Mary Glory Lillian Breckelmans Disability Award in 2019 by Catholic Health Association of India and Lillian Foundation Netherlands. The Henry Viscardi Achievement Award by the Viscardi Center in 2017, Medical Personality of the Year Award by Delhi Medical Association in 2017, State Award by the Government of Delhi for Exceptional Achievement by a Person with Disability in the Field of Social Work in 2016, and the NCPEDP Memphis Universal Design Awards 2013. And we look forward to hearing from you because the topic of the webinar relates to your subject.
It's a great pleasure to welcome Dr. Kamaljeet Singh, who is Professor and Head Department of Ophthalmology, MLN Medical College, RIU, Allahabad. And he is quite inclined in academics, has taught many residents, has been author of a book on manual SICS, then also on Hamari Aankhein in Hindi for layman. Then he was awarded WHO Fellowship on Medical Retina for 6 weeks in USA. And he has also worked at Massachusetts Eye and Ear Infirmary, Boston, USA. He has attended various meetings, international and national, which includes the American Academy at various times. And he has been the president of Indian Intraocular Implant and Refractive Society in the year 2006. He has also been vice president of the Indian Intraocular Implant and Refractive Society and UPSOS, and has also been secretary of UPSOS, chief editor of Ophthalmology and Allied Sciences since 2015. And the journal Emetropia, he's also editor of that. And he has also worked in the UP Journal of Ophthalmology of the UP state. He has performed live surgery demonstrations in various conferences, has taught many residents and ophthalmologists. He has been guest speaker in various national and international conferences, has several research papers, and has numerous orations to his credit. We welcome Dr. Kamaljeet Singh, who is again a very good teacher and has taught many students. Welcome, sir.
It is a pleasure to welcome Dr. Tamil Laxman Senthil, founder and CEO of the WellCare Health System Private Limited. I think he's one person who's completely changed the way the ophthalmic practice should be done, and he runs his own company and his own WhatsApp group as well, which has been very useful to the private practitioners. He passed out his MBBS from Sri Ramchandra Medical College and Research Center 2014, was awarded IRSI Gold Medal from Governor of Tamil Nadu. 2007 got the Volunteer of the Year Stanford USA Award. His topic of interests are diabetic retinopathy screening, telemedicine, dry eye care, retinal diseases, and cataract surgery. He's been a guest speaker in prestigious Yale and Duke universities and received a Humanitarian Volunteer of the Year Award in an international healthcare convention held in Stanford University in 2007. He got gold medal for excellent service in ophthalmology from Tamil Nadu Governor Rosaya in 2014 and has a special interest in diabetic retinopathy screening through telemedicine. He is the CEO of the WellCare Health System Private Limited, which is the India's largest tele-ophthalmology company. We look forward to hearing from you.
We also welcome Dr. BNR Subudhi, who is ex-head of the Department of Ophthalmology, MKCG Medical College, Berhampur, Odisha, and the chairman of Ruby Eye Hospital, Berhampur, Odisha. He has completed his training from the MKCG Medical College with honors in physiology and biochemistry. Then he did DOMS at BJ Medical College, Pune, completed MS in ophthalmology from Berhampur University, and then underwent Vitreoretinal Fellowship from Retina Foundation, Ahmedabad. He had a fellowship at Institution of Clinical Ophthalmology at Kiryu, Japan, under Akira Momose, and has undergone fellowship training at Karlsruhe, Germany in 1996 in phacoemulsification. He has received 5 gold medals from Berhampur University and has published various papers in national and international journals and has presented various papers in many conferences. He has participated in almost all the annual conferences that are held in the country and has also participated in international conference. A vastly experienced person. We welcome Dr. BNR Subudhi in this webinar.
Very soon, Dr. Rajeev Mukherjee, the treasurer of ISCRIS, would be joining us. He's the director and senior consultant of Mukherjee Eye Clinic, New Delhi, and the visiting professor at Feinberg School of Medicine, Northwestern University, Chicago, USA. An established cornea and phacosurgeon, he's presented numerous papers and courses at international and national levels, and he's the vice chairman of the Family Benefit Scheme of All India Ophthalmological Society.
So a very warm welcome from all of us in this webinar. And before we actually start the presentations, I will request our President, Professor Tital, to say a few words.
Thank you, Rajesh. A very good evening to all our friends who are attached to today's very interesting webinar, which we're going to discuss. And definitely on behalf of our society, ISCRIS, and on behalf of our executive member, I would definitely like to thank all the speakers for accepting our request to be presenting a thing which is quite controversial in a way, and in some areas it is well accepted as per the rules, especially armed forces. But there are areas where things are still not very clear regarding the color vision in terms of employment of a particular person and its suitability, which requires an in-depth discussion. Maybe this forum, we can have some thoughts behind this and look into future ways to streamline the guidelines for various requirements and various types of employment which can be given to an individual, right from the medical field to armed forces. In fact, if I see the list of speakers, they are well experienced in their areas. I'm pretty sure that we'll have very correct inputs from these eminent speakers. And as Dr. Kamaljeet spoke in the beginning, most of us would be, taking some knowledge through this discussion. Maybe we come out little more, can say, knowledgeable and aware of the situation which is prevailing in our country regarding the color vision to various areas. And some of the areas cannot be clarified by any discussion, because sometimes it's not only in our hands, it goes to the actual rules regulation made by government, and sometimes they are corrected or remodified by the courts. So I think it's not only the government regulation, it is now judiciary which has come into play. They're going to decide if people are suitable for a job or not. So our job is there, but I think we have to abide with the rules and regulations. Thank you, Rajesh, for getting this very important topic for today's webinar.
Thank you, sir. And we start the first presentation. That will be by none other than Professor Radhika Tandon, who will be talking on visual criteria compatible with professional needs.
Thank you, Rajesh. Thank you, sir. And good evening, everyone. Is it showing? Are the slides showing?
Yes, ma'am.
Thank you for the opportunity. So I'm going to cover the visual criteria compatible with medical profession and also various other professions. And basically, it is going to be the ophthalmologist perspective. Now, what is the relevance of this topic? As ophthalmologists, we are responsible for the technical aspects, and we serve as the facilitator. So as the interface between the requirements of the particular field of employment and then the regulations which are in place. Now, the common scenarios that we encounter are usually people coming for medical boards, medical checkups, or even treatment for their eye conditions so that they become eligible for various jobs. So commonly we will have the various defense services, security forces, including police, CRPF, BSF, railways, and other government jobs. And with various different categories of employment, and even within the different ranges of services, there are different levels of standards. And these get revised from time to time. They're available usually to the candidate based on the information which is released. And it is very important to be up to date and and also confirm as to what is the actual need of that particular person who is coming for that purpose, so that you are able to guide the person appropriately and give the suitable treatment. So just to give a few examples, for example, Indian Army would maybe, or a particular category of post, it may be uncorrected 6/12, and then it may be allowing correction with glasses. And it may be a little different in the Navy, it may be different for pilots, and so on. So every possible post, there are clear-cut guidelines which are available, and it's important to be familiar with that. And also sometimes the candidates do not read it very carefully. So as the healthcare provider, one should engage their attention and make sure that they understand certain aspects. Sometimes it happens that the candidate may have an exclusion factor. For example, the axial length may be more than 25.5, and they still want to have the refractive surgery for their myopia. But then that's with the understanding then that may exclude them from that particular job. But then often they opt to go for the surgery anyway because they want to have the refractive procedure done. So I'm not going to spend time going over each and every nitty-gritty because there'll be no time, but I just want to make everybody aware that one should be familiar with what is the written word and not depend upon memory. And one important factor that one must note is color vision, because often in a refractive surgery workup, color vision may not be taken into account, but it is something that if a person is coming for professional needs and that particular job requires the color vision to be of a particular standard, that should be included in the refractive workup, because then the person knows that apart from the visual criteria, the person is going to clear the color vision requirement as well. And there are a few examples from AFMC, nursing services, etc. I'm just showing you that there's a whole range, and it is not possible that what is suitable for one may be suitable for another. And sometimes there are further details which are specified down to, even the presence of binocular single vision, the visual fields, and so on. So again, I would emphasize that as an ophthalmologist, one should be familiar and one should engage with the patient, know what they're coming for, what they're seeking, and how you can help the person best. Just a little bit about refractive surgery. It is simply a surgical correction of refractive error. And we know as the technology has improved, how now refractive surgery is an acceptable means of correction. Earlier, in fact, one used to spend a lot of time trying to prove that a person had undergone refractive surgery and having to prove that the person actually would be excluded. Whereas now all the various agencies have upgraded their requirements, basically because of the better quality of surgery available and the more stable and better results. And so therefore, when they come for professional purposes, one would usually have a person who will be coming for a particular job or profession. And this is something that one can offer. And here again, I would like to mention some practical tips. Apart from the criteria, one should also look at certain other things like timing. Like, for example, in one of the slides I had shown you, they had required that the refractive surgery should have been done 12 months before the medical test. So these are little things which the candidate may not pick up. So one should look at it oneself and bring it to their attention. And also when they're coming for the workup, you must know that when is it? It should not be that their medical checkup is like next week. So things like that, and see what is the timing, and also warn them that though it's an excellent surgery, though it's a very safe surgery, but there are sometimes unpredictable factors. And so they must allow for the fact that they may not always end up with 6/6 straight away. There may be a little healing period, particularly if they opt for surgery like SMILE, because technically the patient's vision may be 6/6, but sometimes they may have a little blurriness in the first week. So these are a lot of variations. And then, of course, emphasize the post-operative care and follow-up and other things as well. When talking to the patient, make sure that they understand all the other normal parameters which are required to give a successful surgery, because often the candidates are very busy studying, etc., and they have to allow for that extra amount of time for proper post-op care, post-op follow-up, medications, and so on. And then if there's a marginal patient, then here again, don't make the mistake of compromising on safety. If it's a marginal patient is very motivated, even then, always you have to counsel the patient and say that you really have to think of another profession. And I would like to emphasize here that ICL, though it's a very safe surgery, gives excellent results. Presently, it is not accepted by most of the professions where they require uncorrected vision of 6/6. Now coming to a different aspect. So one was that you are giving the person best corrected or sort of a best uncorrected vision of 6/6, or getting rid of the spectacles for those professions where they require to have 6/6 vision unaided. The other aspect is that we need to be aware of is that there is a sea change in the thinking about the disability certification, and the idea is to allow more and more people to become eligible for jobs with the best possible means provided. So this is something that one needs to be cognizant of, and there is this bill which was the National Disabilities Bill, which was passed in 2016, and after that there have been several criteria and guidelines which have been upgraded. One is, of course, that blindness has been understood to be according to the WHO criteria, but low vision has also been accepted and better defined. And just a word of just a caution, because often people may not pay that much attention, but the NPCB definitions would appear to be similar, but the difference is that this is presenting visual acuity, whereas for the visual disability certification, it is the best corrected vision. So though the values and the numbers are similar, but there may be little difference. And if there are any students watching and they're going to answer any MCQs or any questions, etc., it's important to be aware of that difference. Now, coming to the certification criteria, this is important because it can make a lot of difference to the life of the person. And this has been very nicely defined in the Gazette, and that is the website from which it is accessible. And basically what has been done is that the various categories of vision disability have been made a little more defined. So the areas which is highlighted in this pale yellow color, that is coming in the category of low vision, and below blue comes in the category of blindness. And here again, there can be variations and in the level, and this has all been defined in a more clear way. And one thing more I would like to specify and to bring your attention to is that even the visual field criteria has been taken into account. And with this new classification system, some value has also been given to the level of vision in the worst eye, whereas in the old system, it was all dependent upon only the vision in one eye as the better eye vision. So in many ways, there has been an improvement in the understanding and a little more qualification, or a little more objectivization. But of course, no system is perfect, and still you'll have an occasional patient who would sort of, may feel that they are being disadvantaged or being left out of a particular service. And there's this disability matrix, which is the same information which can be put in a sort of simple way to follow. So you will see the vision in one eye, say this patient's left eye best corrected vision, if you take it as 6/60 and say the other eye is 1/60, then it comes down to 60%. And I'd like to acknowledge the help of our community ophthalmology department, who helped a lot in the creation of the disability matrix. Few things to notice: that it is a Snellen vision chart which is used, best corrected vision, and multiple rows. And basically you have to, as I said, this is one example where you take one eye, you see, and then you see the vision in the other eye. And correspondingly, the same thing would be done for the visual fields. Just to give you one example, so there may be a particular level of the visual acuity, but if the visual field is less, as you may have in patients with glaucoma, and I would like to appreciate the glaucoma services in the RP Center, which highlighted this aspect of sometimes the vision is good, but the field are poor, and that can also help you to further help these patients in getting the proper categorization and the benefit of the various services that the government can offer. So these are the field criteria. Again, I will not go into the details because of lack of time, but it is all there in the Gazette. And similarly, the field criteria can also give you an idea, and they come into the various categories of the low vision and blindness. So the visual field test actually is recommended by kinetic or automated visual field, but as you can understand, this may not be there in very peripheral centers. And in one of the previous examples I had shown for professional purpose, they actually said that the fields can be tested by confrontation, and only if there is a doubt, then one may have to go for higher tests. Now, this is important as far as the new disability certification guidelines. Generally, a certificate would be certified if it is a permanent disability or a stable disability. A temporary certificate would be issued if it's likely to get worse. And there's one exception, that is students, because you may have students who are required to have a writer or a help during the exam exams in school or college. So in those cases, it may be a disease like keratoconus. It may not be the right time for that person to go through surgery and all those other surgical measures. So they can be given a temporary certificate to help them complete their education and help them for employment. Regarding the medical authority, earlier the certificate required a full medical board, which had at least 3 members. This has also now been made more simple, where a civil surgeon can give the disability certificate. Now, is there a maximum or minimum age? There is not. There is no limitation, and various benefits for visually impaired are also available. And this is the same thing repeated. So therefore, just to think from the guidelines of the medical professional point of view, a newer aspect has come in about the MBBS students and postgraduate qualifications. And here it's a little bit more complicated because already we have best corrected vision. If you saw all the other professions, they had required unaided vision of 6.6, 6.9 and so on. In the medical profession, best corrected vision with any possible means can be included, including using various devices. And so in this criteria, the better eye, practically it amounts to 6.6 or 6.18 vision in the better eye. The worse eye could even have no light perception. So a one-eyed candidate would be qualified to become a doctor and even pursue PG. After treatment of treatable disease and with corrective spectacles, and better eye fields are used to determine the percentage. These are just a few more guidelines. Everything is specified in the Gazette. A word of caution to all people who may be involved in doing the certification: always do a clinical examination, look at the diagnosis, and findings should be commensurate with the vision. And assessment should include a review of the past medical records for reliability and consistency. And if one is not sure, then it is better to defer and wait till one is sure as to what is the actual, because the disability certification has to be taken in consistency with the guidelines. And now at a higher level, you may require much more equipment. So if in a smaller center, they are not able to discern or probably able to give the certification, then the person should be sent to a higher center. And here I feel RIOs should be all equipped at all medical colleges ideally, and definitely the RIOs should be equipped with all the required devices to help people take the maximum potential of their vision, whatever it is. I'm going to run through a few slides to just make you aware of the various low vision devices which are possible and the rehabilitation opportunities. So therefore, it will allow the individual to adapt to the daily activities, and it can be very important to integrate to their socioeconomic and their own personality development. And now, literally, there are so many new devices coming up that it's very difficult even for us to keep up with it, but it's very important to remain up to date. And basically, as the evolution of distance low vision aids have evolved from telescopes to several high-tech devices, there's a great era of change. And giving you a few examples of where, spectacle mounted devices, which are more handy, easier to use, and they can be convenient. Similarly, we have these CTV spectacles, which can be used where a person can see distant objects quite well, and various bioptic glasses, and New Eyes is available as a digital device for distance vision. A lot of them actually are now much better looking and much more handy. And some of them can be also aligned with the smartphone and can help a person with a lot of daily tasks. And similarly, near low vision aids have also improved a lot. So they can be video magnifiers, desk magnifiers, which are much more easy to use compared to the various previous devices which were available. And even for the visual field, there are some glasses which can help in the visual field enhancement. So, and one more thing is the various low vision apps, which can be used with smartphones. Largely, these are helpful for near activities, but the binoculars device can also help a little bit for distance vision. However, there's still limitations with all these devices. They do help a lot, but compared to the ones who improve the distance vision, they will limit the field a little bit. So the person requires practice and requires time to get used to the devices to know how to use them best. I'd like to thank all the various people who help in supporting supporting this work, and of course the inputs we get from community ophthalmology, glaucoma, Sneha Agarwal, who helps us with our low vision clinic, and also Nimi Raj, who's a senior resident, who helped with doing all the research on the criteria for various professions. And I'm sorry if I overstepped the time. I tried my best to condense it into as short as possible. Thank you so much.
Thank you, ma'am. It was really a very nice presentation, very good coverage of this little bit tough topic, difficult topic. I would like to have opinion of Dr. Sulata Bhandari on this topic, and then of course we can discuss.
Yeah, very nice talk, madam. Extensively covered. Yeah, there are a few points, as madam mentioned. Whenever the people come for certification, we see most of them are from either from railways or some of the companies or armed forces, etc. Usually they come with the criteria along with them. So it's easy for us to tick it. I just had one doubt to madam as well as other speakers. Recently, I had a child, like a 9th standard boy, who came because he had heterochromia. He wanted to join one of the military schools, but only because of heterochromia, he was referred for a second opinion. Is there like, I don't know about it, is that criteria to give any disability or this one for
so there was one of those papers which showed the Sainik schools criteria. I don't recall seeing heterochromia as an exclusion. It should not cause any difference in their in the vision or the performance. But there is the Sainik schools one which I had seen. I don't think it should be a disqualification.
Yes, ma'am. Yeah, even I had written the same, but I was not aware what to do with the heterochromia part. And coming to the professionals, I think we are looking at all others. Like I was just going through some papers and they saw that ophthalmologists, when you come to the criteria, there are not many except 2 countries, maybe in Czech Republic and Netherlands. Only there they have criteria. At least the stereopsis, maybe for ophthalmologists, when we check, when they join, it would be a good idea to check, I think, when we look at these visual disability criteria. And as you mentioned about the other disability criteria, we are very happy now. The new Gazette has given us a very good guideline for issuing the certificates. And most of the time, though we give a one-eyed person as a 30% disability, the court or the judge decides upon the future prospects and the employment of the patient. And sometimes they give like one eye is gone, so 50% disability. This is what we have seen. I think that's all. Excellent presentation, madam. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, ma'am. Actually, there are various points which we need to clarify, or maybe we have to keep working on, because sometimes we do get some individual who is having 6/6, having good color vision, but particularly from railways, they are sent to look for the evidence of any previous refractive surgery. So I don't know why. What is the need for that? I mean, that's what I always feel.
So this was a little bit earlier when refractive surgery was an exclusion criteria. Most of them have updated. I will have to check again if railway still excludes refractive surgery. Maybe for engine drivers, they do exclude it because they think that maybe, I'll have to check. I don't recall. But the others have more or less eliminated it as an exclusion. Railways, I'll have to check.
So what about the cataract surgery, ma'am? Supposing somebody has got cataract surgery done and is appearing for a medical test.
Right. So this is for medical test, for generally they have not, you just need 6/6 or whatever vision unaided. If you're a pseudophakic person and you have that vision, it's not a contraindication.
Okay.
So it's
not. I was going through the literature. They have not mentioned. They have mentioned the refractive surgery, but not the cataract surgery.
Yes.
pseudophakic.
Radhika, yeah, I had a question, and we keep getting these queries from.
Sorry, just 1 second. But however, if you see, the army had also wanted N5 unaided, if you see. So you have to look at it very carefully, which profession it is and what is the need, because in that case, that cataract surgery would not be making the person eligible. And
at the time of entry, they say this.
And then also, if you see, there's more detailed one about ptosis and, so
Yes.
one will have to really check for
Yeah,
each
yeah.
and every point for that.
Yes.
Sorry. So yes, Namrata.
Regarding cataract surgery in railways, I was part of that guideline making, apart from the refractive surgery also. Earlier, railway engine drivers, as soon as they used to get a cataract surgery done, they were given a retirement. But after this assessment, we made a criteria: vision can be improved to 6/6, and our binocular function is there. These drivers should be allowed to work, and their medical assessment has to be done every year, so that we pick up any deterioration in their vision quality. Now, even people with cataract surgery done, they can still continue even a railway engine driver also. As far as refractive surgery is concerned,
for engine drivers, is it mesopic 6/6 vision or photopic 6/6 vision?
both
Mesopic
have to be
also.
tested. Yeah, because they are working in a different light conditions, where they have a different criteria to check the vision also. Both are included. And apart from that, field of vision is also taken into consideration. As far as refractive surgery is concerned, railway allows, less than minus, I think minus 3.5 or so refractive error with corrected vision more than 6/9 in other jobs. But the major criteria was some people had a -6, -7, and they corrected, 50% of refractive error, and they were, coming for these checkups. So there, the excellence was made mandatory for these patients to be looked into. I think the cutoff we picked up was 25.27, I think, excellent. Anything more than 25.27, they were eligible for this suitability for medical job. So apart from the refractive error, the visual acuity field, as Radhika pointed out, the axial length has become an important criteria, and the corneal thickness. And same thing I did for a Delhi police also, because a lot of people are coming with a refractive surgery. These criteria were put. Apart from that, because they are working in a night condition, other condition, their contrast vision was also to be assessed in these cases.
How do you confirm that the refractive surgery has been done? In some patients, they have 6/6 vision and they come to us.
Op scan?
What op scan would?
No, in that you have a parameter, the keratometric pattern deviation, the KPD, and if the KPD values are outside limits more than 1.5, then you know that even if it is a PRK, then you can make out that a refractive surgery has been done.
Yeah.
And,
even the pattern of map, ma'am, like
so
normally it's
KPD, if you see, you can make out. Radhika, I had a question, and we keep getting these queries from all over the country, and that is that one-eyed individuals are being given driving license. So everybody says how justified it is that a person who's one-eyed and is not able to see one part of the field would definitely be not as big as when you are seeing bilaterally. And in states like Tamil Nadu, etc., they've also represented, against it. So what are your thoughts or views on that?
See, one-eyed people are not given a heavy motor vehicle license, but light motor vehicle license they are given. And even internationally, an estimate field of 70 degrees is what you can get with one eye. So definitely there is, or compared to having both eyes, there is a little handicap, but they get adjusted, and if suddenly a person becomes one-eyed, it will take a little bit of time. But the people who have been using one eye for some time, they have adequate range, and they should not be excluded from getting a license.
And what about
perception? Can I ask a question?
Yeah, they get their binocular clues, or with experience they get the adequate depth perception. So if you test it, they will not be having proper binocular acuity, but they're able to have reasonable depth perception to be able to drive. Yes, Kierti?
Wonderful presentation, Radhika. You went through all the gamut. what I wanted to ask was that we do a lot of these disability and these fitnesses. Now, exit length criteria, as Dr. Tityal is saying, and you have said, it may be there in the gazette, but in the guidelines which we get, for example, we have for fire engine and for police people. Nowhere in their guidelines when we ask for them is exit length mentioned, and it just says that refractive surgery, any refractive surgery, whether it is 6.6 or 6.5, they're out. Which, if you are again in the process of devising it, I was again told, I haven't done my homework recently, but I was told that even NASA people, refractive surgery, the astronauts are permitted. Whereas in fire services, they are not. And these children very often just have -2 diopters of, -2, -3, -1 of myopia. And because they are so anxious to get into service with 6.6 vision, they go and get that cornea chopped off. And then they are said it's unfit. So maybe the people who are there who can affect these, just either refractive surgery, since it's become so safe, these criteria should be really looked into again, and not only looked into for the gazette, it should be disseminated to the various authorities like fire services or police services. Army has its own authority. It will not be party to this, but it should be disseminated so that everybody has the same criteria.
Yeah, good point.
Radhika, thanks. It was a wonderful presentation, and I think it gave us a lot of clarity. And I think this gazette was long overdue. So I think it's a effort in the right direction. I had a quick question about color vision, and I know it's been entered as one of the criteria, but I'm not sure if there's clarity on the subclassification of the kind of color vision and how much disability that would involve. Suppose someone comes in and misses, say, 2 plates on the Ishihara or 3. Where would you really classify? Would you have to send him to a board?
So Kierti is going to cover color vision next.
I'm going to cover that, sir.
To cover that next.
Okay. I'll wait for Kierti's presentation then.
Okay. So let's move on to the next presentation by Dr. Kierti, and ma'am will be presenting on.
I think Chandana wants to say
just
something.
one query, please.
Chandana,
Yes.
you unmute yourself. Unmute yourself,
Chandana.
Unmute.
Actually, hello.
Yeah, we can hear you.
The drivers, the transport companies, we visited 10 transport companies, the tram companies, and we were surprised that the visual acuity of means almost 40-50% of these workers, employees are very poor. They are below standard. So that means when we asked, they said that they don't have this follow-up things. That once they entered in the work, then after that, there was no follow-up. Do you think that that should be included in all these professions? That is very necessary, I think.
So you mean a periodic medical examination?
Yes, periodic.
Yes, ma'am. It is, it is mentioned for especially for the commercial drivers. It is mentioned that annually they have to undergo a checkup, especially one-eyed patients. They have to undergo a checkup, and with the field of 70 degree, even a one-eyed person can get commercial driving license, but they need a annual checkup.
Sorry, can I interrupt?
Thank you.
But normally we do not see any annual examination of drivers. It's very common in our part also. And we don't insist also. Whenever we do, we really surprised to see a lot of people, 50% they drive in guards also, guards.
Yes.
It's interesting that observation is there, because at the Automobile Association, we did studies for them, and amongst their heavy vehicle drivers, 36% of them had significantly subnormal vision. And most of them were just refractive errors. It wasn't something that was organic, but it was just that they weren't using glasses. And I think that's where the emphasis has to be. They must get an annual check. And most of them don't have serious disease because they're generally young people, but they do have refractive errors. And that seems to be the biggest bugbear. And we did this study 2.5 years ago with the Automobile Association here in Delhi. and we found that 36% of them required glasses.
Yeah, maybe I guess because of that, because it's very difficult to force them to wear glasses, and many of these people who are in that strata, they don't like to wear glasses. So
Yes.
maybe the criteria may be changed to having uncorrected visual acuity of better than 6/9 or whatever. If you have got corrected by any refractive procedure, I guess that should be there for drivers.
Dr. Rajesh, sorry, you will be opening a Pandora's box there. Same way, all those people will go and get a LASIK or PRK done, and then they would have problems. I think it's better to convince them to wear glasses, and glasses are cool and they're good, and rather than try to go away without glasses.
But one
I
concern
think
is the basic
one of the aspects that one will have to consider is the legal side of this, and if anyone who gets into a mishap is proven to have a negligence because of disability, and he has created an accident because he didn't see well, and if that can be proven, then insurances and other things can come in, and that until that happens, there'll be no accountability really for anybody wanting to wear a glass. So I think in the end, a little bit of danda works. Beyond that, voluntarily, Rajesh is right.
I think
What
that is a
about
very good
a
point,
case
sir.
where you have
Annual checkups are mandatory in many workforces. And until and unless you do that annual checkup and that danda, as you are saying, that unless you clear the annual checkup, you can't go ahead with your job. That should work.
What about a case where you have a central posterior subcapsular cataract and vision is 6/9?
Drivers, difficult. Again, mesopic, scotopic, photopic, all those, pupil dimensions would change. And even if it's 6/9 in one set of lighting condition, in the other lighting condition, it will be very disabling.
Yeah. In bright light, they can't see anything.
That's exactly what I asked you to tell in the first place. Mesopic and scotopic, especially for engine drivers, when you have a rexes of 6.5 or 5 and the pupil goes beyond that at night, what would be the mesopic vision at that time, and that should determine it. Just like you have for the pilots and for the for the army people, it's in different lighting conditions. The same should be for engine drivers because they carry a lot of lives on stake. Can
I guess we can have more discussions later. Ma'am, can we start?
Should I? Okay.
Yes.
Thank you, Dr. Rajesh and the team for having this one of my favorite topics, which I've been working in the last decade or so now. And I think in this August audience, we have a chance of making a difference and modifying the archaic gazette. So the topic given to me was color vision criteria for medical students. And I've added a little to it, need for a rethink to provide justice with focus on clinical impact on patient care. And why is this not working? Is it visible?
Yeah.
Yes. Okay, fine. So why we are here on this platform for color vision is that India, for some reason, is on a different journey vis-a-vis the rest of the world. Whereas most of the Western countries, and let's say UK, for example, where Dr. Anthony Spalding was the first one to toll the bell in Confessions of a Colorblind Physician. And he said there is a little response despite number of publications and there is no appropriate action and you need action. However, in no Western country, our doctors with CCDV, congenital color vision deficiency, are not debarred from training in the specialty of their choice. Whereas it is spotlight is on India. Remember your MBBS days. In the first year, within the first week, you would be taken to a community medicine department and this Ishihara test would be done for you people, which we've been doing, and you will be tracing these numbers. And sometimes, in fact, most of the times, the first time you'll know that you have a color vision deficiency and oh boy, did you have it? Okay, and you didn't even know that you had it. And this is a small video clip which my residents made on how the picture changes once they come to you. So this is the actual situation which we face as ophthalmologists, because that's what the Gazette says. And to answer Dr. Rishi's question, sir, it is little vague for many jobs, like for technical means army or the drivers or the engineers, it says higher grade of color perception. And if you take Ishihara's, less than 3 is taken as normal. I mean, less than 3 color division, if you don't read the plates. Now, excluding the first and the last plate, it's taken as normal. You can make those errors. And up to 8 is taken as low, and more than 8 is taken as high. However, mind you, once there are ambiguities in the Gazette for color vision, because it talks about Eldridge lantern and not about Ishihara all the time. And the Eldridge lantern, as all of us know, is not frequently available. And even if it's available, it's not that reliable, because I'll show you why in the next couple of slides. And there's this caveat, if you read that normal color vision, provided the board is satisfied that the candidate can perform all the functions of the job. So here it is pretty ambiguous, and it leaves it to the specialty concerned that what they want. And this is what we have been using as medical professionals for our peers and for people or doctors who have an issue. And we can use this that, okay, if the anesthesia people are comfortable, let the child do the PG in anesthesia. If the surgeons are comfortable, let it do. But it leaves these children at the mercy of seniors who may or may not be helpful or understanding. And we have Satinder with us, and this is one of his publications. It is not a disability. As per the Disability Act, color vision deficiency is not a disability. And although that severe CCVD may affect decision-making of these students, in the absence of evidence-based guidelines, these students are arbitrarily debarred from specializing in some disciplines, which again is not justice. Here it says, again, in the detailed ones, if you look at the railway services, IRTS, IRAS, they will specify that lower grade of vision can be considered for some services, and Ishihara and the suitable Eldridge clean lantern. But mostly it talks about Eldridge clean, as I showed you in the higher aperture and the smaller aperture. This is what an Eldridge clean lantern looks like, and I'm sure not many of us have recourse to it because it's a pretty old, archaic instrument. And this is the large aperture. If you can see this yellow, green, and red, it's supposed to be low. And if you can't see the smaller aperture at a distance of 6 meters in ambient light, it is a little bit mesopic light, not in a bright light, and then it's considered to be a higher grade of colored vision defect. Now, coming to the medical doctors, we were talking about the judiciary. Now, judiciary already has said in various different court cases that since CCDV is not a disability and students with CCD can become doctors and can pursue their training of their choice. However, despite that Supreme Court guidelines, it has not been endorsed by most governments. And please remember, health is a state subject. So none of the governments has really endorsed these guidelines. So till date, there's a despair, bewilderment, and frustration of our student doctors. And since 1997, when I joined as a faculty, I found that these tests of Ishihara and Eldridge lantern, which came later because we didn't have that initially, they do not accurately predict the real life performance. These are the current guidelines that Supreme Court has directed admissions of students with color defect, but it is ambiguous on what defect stage or what severity. So we devised an album where we wanted to actually see how these CCVD patients or students fare in clinical situations. We want to identify the errors and generate a color album test and clarify relevance of Ishihara, which is still used for grading color vision defect by most medical colleges. It was a cross-sectional study design, and we had these patients, students of MA Mulanathan Medical College, who were color vision defective, who were screened with Ishihara, and we compared them with color normal controls from the same hierarchical groups, and we excluded those with a systemic disease who could have color vision problems. And this was a picture album generated thanks to my team of specialists from different specialities. We did generated an album, And screening test was done by the default Ishara. And sir, as I told you, more than 3 errors were taken as CVD as per the guidelines. Then we did a Farnsworth D15 test to categorize and type the severity of the CVD. And the color album was given to the students, and they were asked to do the tasks on the album, and the total error score was noted. Of the 42 students identified, only 31 consented. Prevalence was lower than the normal of 8%. Here it was 2.8%. And of the male population, it was 4.8%. Now see the stigma, because these are students who are well aware now that they have CVD defect, and they do not want to be identified because they fear of the stigma and the labeling this thing will give them. Deuteronomy was the commonest subtype identified, followed by deuteranopia, and protanopia was the least common at 13%. 6.5% did not conform to any subtype on D15 color arrangement. These were the color photographs of clinical scenarios relating to clinical, pre and paraclinical medical specialties. They were collated into a color album, and this validation of this test was done. And these are various pictures which our faculty gave us. There was a positive correlation factor of the color album test with Ishihara. Student perception was that this is more realistic and more, obviously the severer the CVD, more were the errors. Protans had a more problem with all these clinical tests than deutans, and mind you, protanopia was less common. Seeing shades of red during hematology, blood grouping, peripheral blood smear, Zeal-Nielsen, diagnosing melena, entering skin size of lymphangitis and tinea or miliaria were problematic. Red blue differentiation of skin signs of age of the bruise, peripheral cyanosis, and green differentiation on hemolysis on blood agar were identified as problematic. Minimal errors were seen in interpreting mucous signs of Shavik sign, pharyngitis, and otitis media. We thought the student would have problem with this, but they didn't. In addition, many of them used stereoscopic clues to reduce their CVD errors in these pictures. So this was the color album, and this is how we asked the students to do the test. They were asked, the error score was calculated. A questionnaire was taken from them, and it was a questionnaire devised by us for understanding the self-perception. And we found that 90% of students coming to Mulananda Medical College were unaware of the CVD prior to the screening. And this was in concurrence with the reports of the previous published literature, that many of 2 out of the 3 people of color vision defect were unaware of this. What is the relevance of this? That if these children are made aware of the limitations early in time, then they can adapt, they can use their adaptive strategies. These strategies, anyway, the mind is making constantly, whether the child is aware of it or unaware. But now, if they're aware of it, they can understand the limitations and are more likely to make corrections. Positive family history was only seen in less than 1/4 of our students. Of the 52% who had a driving license, only 38% of these children actually had a color vision test during getting the license. 19% only complained of difficulties in school, and chemistry was identified as the most problematic subject. This was again a retrospective analysis. That when you ask them, then they said, yeah, yes, I think we had these problems. And the natural strategies which they had adopted without realizing were increasing illumination, comparing with other colors, contrast on stereoscopic clues, experiential learning, logic, and peer help. So this conditioning had already happened because these children were born with this color vision defect. 13% said they would not reveal their CVD. They would not seek help. 26% said they would not undertake this test, study because of fear of stigma. All of them wanted screening, but 32% said it should happen prior to the medical entrance exam, and 23% said prior to joining. Rest were unequivocal. Counseling was asked by most, and 58% said that the CA test was more realistic and relevant, and Ishihara score did not reflect. So yes, CVD students do face difficulties. Dermatology, pathology, hematology, microbiology, and biochemistry were identified by this study of ours to be more challenging. And for pediatrics, medicine, ophthalmology, specific training in use of adaptive clues helps. CVD screening is must. informed career choices, because the student sometimes doubts his own learning ability if he fails to detect or correctly assess a physical signs characterized by color. Since it is not a contraindication for joining medical profession, it is totally unethical to debar these students from pursuing higher education or becoming a faculty in the same profession or getting a government job. And we need to rethink that Ishihara is not realistic. A CAT test or something similar would be more realistic. Safe clinical practices can be adopted by these children. And this has been again multiple times stated before that none of the doctors who were identified by other countries also were given any help or advice regarding the deficiency. Some states do help in giving the CBD students monitors adjusted to grayscale and learning to compensate the deficiency. However, most do not, just leave it to them. Colors, we are surrounded by colors. Colors dictate our decisions, often conditioned decisions. And by this study, we showed that these students, they were already conditioned by their congenital deficiency from childhood. And these guidelines which the Gazette has are extrapolated from recommendations used for navigational personnel on the time Shinobu Ishihara was asked to identify why this train or this steamer ship had an accident. There's a lack of contextual perspective regarding the ability of CBD doctors, and it is neither ethical nor technically correct, as any screening test for fitness to practice should be combined with giving career advice. Since these altered color perceptions are there since birth, they have developed adaptive clues. I repeat, it is unethical that without counseling, they are asked to complete their MBBS, but later they are told that they are unfit. Nothing about us without us. Ask them what problems they have. This is the mantra of all disabled people. And here in this CBD, in any way is not a disability, but at least ask these students what the problems they have is, and do not block their students from joining a PG course that they're otherwise eligible for. So join us in this color crusade. And that's what I want this August audience to join in this color crusade, because India is the dubious distinction of being the only country in which medical students are debarred, or even doctors are debarred from pursuing post-graduation or becoming specialists based on their color vision defect. Thank you.
Thank you very much, ma'am. And it was a very, firm statement, and I really liked it, actually. I would like to have the comments from Dr. Channa Chakravarti. Dr. Channa.
Yes. Thank you, Professor Kierti. That is an excellent presentation. Actually, when Rajesh told me that this will be the talk, then I thought I'll know very little actually. But now I am a bit confident that I know something after going through the topic. The only one country I could find in literature, that is Taiwan. They have an bar to the medical students. That is the only one country I could find. And Japan,
sure on that, because Japan was the last country which there was a bar to the medical students, and
Japan, yes,
and that was again a female ophthalmologist. I forget the name. She led a crusade, and she is my role model right now. And in 1930s or 40s, I think after the Second World War, it was stopped. I don't think Singapore has a lot of countries.
No, I actually found it. Only yesterday I could get this information that Japan, they said that Japan, they had the bar, but since 1985, they took over it. Only Taiwan is the only country who was still continuing with the bar to the medical students.
Okay, because the Singapore study, which I'm quoting, ma'am, the study from Singapore, which I just showed, they said that students were checked, but they were not counseled, and they went on to finish their MBBS. But no country other than India is where it does the check, allows entry into MBBS, but at the time of PG, it says, okay, you can't go into specialization. And there, Dr. Rishi, which you asked, is the low color vision and the mild color vision. more than 8. So it's very arbitrary. It just leaves them at the mercy of sometimes even at the mercy.
What I feel is that this is a very, very neglected topic.
Yes.
It means very few people actually think about how the child is actually, how the impact of this color vision blindness in a child, the impact that they actually try to hide it always. They try to hide it. They are embarrassed.
Yes,
but
they hide it.
They are embarrassed. They are especially the general practitioners. They are the worst sufferer, the general practitioner, because they have to see the surface colors, the cyanosis, the erythema, the macules, the papules. They are the worst affected. How they
ma'am, the study by Dr. Anthony Spalding, he did confessions. He was the one who opened the Pandora's box, and he wrote all these publications after he's retired from practice. And he's a protanope. So if it's a protanope, they have the maximum problems in milia and this erythema and the mucous membrane signs. But the commonest error is, ma'am, deuteraminal anomaly. So in those, they really don't have that many problems. And remember, we're talking about medical students here. Color is one aspect of your diagnosis. There are many stereoscopic clues. There is history, there are ancillary signs. If these children know about it well and know beforehand, they are intelligent people and they can use their adaptive clues very well. Having said that, ma'am, I personally know many of my ophthalmology friends, many of my surgeon friends who are color vision deficient. We don't call it blindness anymore. We say it's CVD. And they have no problems. They're perfect surgeons. And if it was such a problem, why would no other country talk about it except India? Because it was there in the Gazette and nobody has bothered to change it. And what you are saying, ma'am, is these red milia and the tinea and all these red protonams, they have more problems in the dark light. That is why pilots, navigational, that is why the first accident of the steamer, which led Shinobu Ishihara to find this Ishihara book, was in dark light. Now, none of the patients are seen in dark light. They are seen in good lighting conditions. And that is one adaptive strategy we can use, ma'am.
Now, actually, now there are some fields how they can improve their activities. Like I could find this Wiley online library. They have a whole website where these people, these colorblind CCD people, they will be guided that how you should go and the practical things. This is it is there written nicely. You should avoid this one. You should see this thing like this. They depend on some cues. Cues means rather than the color, that depends on the more on history. History, size, yes, size, shape, all these things. And sometimes, yes, they can take help from their colleagues also. Yes. They can also help them by interpreting the various colors and all. And there is another thing, this is in California, Berkeley, California. They have found out that Enchroma is a company that that has come out with this special type of spectacles. These spectacles, they by the use of these, they can overcome this color vision defect. And another thing is that these graphs, charts, and all these things, especially in this digital era, all these things, they can be guided that they for the color vision defect people, that should be they are making it in a separate way. Means totally they are omitting the red color. They are keeping the red color, they are omitting. They are not keeping the red color. That's why I came across.
Ma'am, actually the X-chrome lenses have been designed and these triple glasses are there, but they are so easily identifiable and they're so difficult to wear. If you wear an X-chrome lens, ma'am, you can see it from afar off that this patient has a CVD, and these children anyway are very sensitive. They don't want it to advertise it. Yes. So even if you have the X-chrome lenses or the spectacles on, they will not use it. Because, and second thing is, ma'am, in the medical, we talk about a medical professional, you rightly said in the digital era, they have other clues, texture. Like we found that these students have the maximal problem in microbiology, biochemistry, and in skin condition. In derma, you have other clues which you can help. And let us also remember one more thing.
Gastroenterologists are also the
ma'am, they didn't have any problem. We thought Melina would have a problem. We thought mucous membrane sign would be a problem, but these students did not have, at least our study group did not have. Ma'am, actually what, the other thing is that I would say something very different, which I've been thinking of this over the last 1 decade. Like for you and me, red means this. But for these people with protanopia, red doesn't mean my red, but it means red to them because his mother and father told them, beta, ye red hai. Unko red, it may not be looking like the red which we see it as, but they will still say it's red, ma'am. They would not say it as my red.
And the thing is that they feel still handicapped, but they don't expose
they don't express that because they have not actually.
The most important thing is that I think the counseling is very important. That is the most important.
Counseling, and it's unethical. I would go on the feature. Either you debar them from, if Taiwan is doing, ma'am, let me recheck my study. If Taiwan is debarring them from MBBS, good. But in India, we're not debarring them from MBBS. But after MBBS, we're saying you can't do anesthesia, you can't do ophthalmology, you can't do ENT, you can become a community medicine person, or you can become an anatomist or physiologist. I don't know. That's not done. And again, and secondly, I'm saying they have the additional clues. It's not only color differentiation, which is important.
Yes,
so
they are somehow managing the thing. They are. But I think from the school days, I think they should know that, yes, I have got this problem.
They have been conditioned to it, ma'am. They are conditioned to it. They've adapted to it very well.
That's very true, ma'am. Just a word about ma'am.
I wanted to add is that you're absolutely right, Kierti. And in All India Institute, we do not exclude them. We've had color deficient people who've even done ophthalmology. We never exclude them from anything, either MBBS or from any post-graduation. What is done is then when we detect the color vision deficiency, the concerned department, we do mention to the head of department and we get a clearance from them. But we've never had a case where we've ever debarred any student of color vision deficiency.
No, but as per Gazette of India, when we sit in the technical board of 3 people, ophthalmologists sitting in a special board, that's how this study was born in my mind. From 1997 in GNEC, we sit for all technical boards of all the government of Delhi boards. And if the child is color vision deficient, CVD, more than 8 errors on Ishihara, it is CVD. And if it is CVD, then it's a discretion of the medical board to make you fit around because
we always pass them. We always pass them. It's not at all.
Good, but many people don't. And I'm telling you to everybody's face, many people also ask for money to pass them. Many people also give
that is different issue.
I guess
I think
that's a different issue altogether, ma'am. Yeah. Just one word about X-chrome lens. I've used it in a few patients, and what I have felt that what they say that there is a dominance of one particular hue. If you put one hue, then the other hues are a bit suppressed. That is one thing. There's a question that has come from Dr. Kamini who wants to know that, we keep talking about we have been talking about the medical profession, but even for electricians, for sweepers, etc., when the medical fitness is done, we do color vision test, etc. So do we really need that color vision test for electricians or?
Yes, definitely.
So this is an occupational, hazard in the sense that it's an occupational need. Now for electricians, they are knowing that this red is a different red, but it is a red. And this green wire is a green, but it's a different green from what you and me would know. So if you have to actually see the delicacy of what they are doing. If it's a very tricky situation like a navigator, yes, color vision test is definitely mandatory, and even a small error would lead to loss of lives or jeopardize the aircraft. Definitely it is out. For army personnel or for people who are working in dim light where color hue and saturation is affected, yes, it would be. For people working on toxicology labs and people with meat processors where the signs of aging of the meat would be changing, yes. But for electricians who are dealing with the regular work, who know red and green differentiation, or for people who are not doing work of that discrimination, no, it's not required. That is why the discretion of the board in what task is asked.
There's another question, ma'am, which you have already covered partly. That is by Dr. Suru. Wants to know, is it necessary to make someone read all the charts, the Ishihara charts?
Yes, it is. Yes, it is. And the first and the last chart, anyway, just to make them comfortable, yes, it is, because the error score is based on reading all the charts on the 36 page. Yes.
Ma'am, there is one thing about grading level of color perception from the Indian Armed Forces. I read about that. And they say that the grading 1 is correct answers to the series of colors with the smallest aperture of Martin lantern test at 6 meters.
Yes, ma'am.
And color perception grade 2 is must pass the Ishihara book with no errors. And color perception grade 3 is should be able to recognize white, red, and green color signal correctly at a distance of 1.5 meters using largest aperture. So this is the grade 3, and they have no problem with grade 3 vision for the armed forces. I mean the army people, but not for the naval and the air force.
I showed that enriched lantern to you. There are different aperture sizes, the mild, moderate, and severe. It's written how much aperture size and everything, and the 6 meter. Now, army is something which is very stringent about some guidelines. So their armed personnel who are in the ground staff or the naval staff or the air force staff, they would have different guidelines for this. I think what you are reading, sir, is for the ground staff, because for their naval staff and for their air staff, definitely they
that
do
is not
have,
allowed.
Yeah, so they would have they have very stringent guidelines.
So is it the same for the medicos also?
Those I just showed you for that Gazette of India is for technical and non-technical, and for technical, low color vision deficient is so-called acceptable, and high color vision deficiency is not acceptable. So moment you cross 8, it becomes high color vision deficiency. Moment you say beyond that big aperture, it's high. So who says what? So for the currently for India, yeah, it is the low one is acceptable, high it is not. But as I said, this is at the discretion of the governments, because all the state governments have not endorsed.
Many a time I feel that we are in the nursery class and you are teaching us the graduation.
Because I've been discussing this at various forums, and I think I believe you are part of the Pan India Ophthalmology Forum where this was discussed.
This was discussed. Yes.
So we move on to the next talk now.
Yes. Go that please, anybody who's listening, do not disqualify anybody for color vision. For nursing or for technicians, what you can do is, if you are concerned, you can get that person, spend a few days in that department. Like, for example, we had perfusionist in CTVS, etc. They have to look at monitors, just confirm if they can read the values. And as Kierti correctly said, they have their own way of differentiating.
Very right.
So please don't disqualify.
I know many colorblind ophthalmologists who can do very good surgery.
Yes, sir. Same.
I know many myopes who do good surgery. They are not having stereopsis.
That's why they are not barred from the thing. The thing is that what I feel is that this means this is a very, very neglected subject. Only one color vision for 5 marks question short note comes in the exam. That is the only thing for the UG and for the PG. And many of the ophthalmologists I have seen, they don't know. I think this Ishihara chart is a fantastic one. Though fantastic, only thing is that how the interpretation of Ishihara chart, that should be taught to everyone, every ophthalmologist. What are the different 5 types of plates are there and how you calculate it. These are things should be taught. I have seen there is a lacune in that part.
I think
before you finish this, just 2 points to be, you Kierti and other people should keep in mind. One is the negligence of the person who is colorblind, and the person who has cleared that colorblind to be fit for that profession. These are 2 issues has to be looked into, whenever you are thinking of making somebody fit for a profession.
So we have Secretary of the AIOS and the Chief of RP Center sitting there. Can we have some guidelines on this?
No, I'm just saying, like there has been one case where a person or the physician who was doing a medical examination missed out the RK incision. mini arc incision. And subsequently, that person was debarred from the job, and the doctor also was debarred from the job.
And I would ask you a counter question. Is India the only country in the whole world who is bothered about this? Baki sare kyun nahi sochte, sir? They are much more vigilant about malpractices. They are much more vigilant about cases happening. Now, nobody else, no other country talks about color vision deficit in doctors and being debarred. Why only India then?
I'm not just saying
So
color
it
vision.
is a problem.
In fact,
It is a problem, but it has been made into a huger problem than it actually is because it is not
somebody
rational.
has to answer the suppose we have some mishap happening from anybody, and later it was found to be a person was a colorblind. Then the entire investigation will direct to that side. Then the question will come: how did this
Sir,
patient
it
was
can
killed?
happen with anybody who is not colorblind also. So how will you? That's a confounder. That's one aspect you found for making any such statement that this aspect happened because the student was colorblind or doctor was colorblind. You have to prove that it cannot happen in a non-colorblind person. So
that's the different issue. If somebody has a disability, then question will always.
It's not a disability. That's exactly what I'm saying. As per Government of India, color vision, Dr. Satinder is sitting right here. It is not a disability. It is not classified as a disability as per Disability Act of 2016. और फिर भी आप उनको disabled हम बोल रहे हैं जब disability है नहीं उनकी. Law of the land says it's not disability.
We'll get back to this topic, ma'am, after the talks are over.
I think we need a whole webinar to discuss this color vision.
Yeah. So Dr. Satinder will be talking about barriers and enablers for people with disabilities in health profession, education, and practice.
Screen visible?
Yeah.
Thank you so much, everybody. Good evening, Professor Tutial, Professor Sinha. Thank you for giving me this wonderful opportunity. And as Dr. Kierti Singh has said right now, that India is lagging behind. So let's see what are the other areas where we are lagging behind from the developed nations. My first question is that I am leaving with you 3 pertinent questions before I begin my presentation. Can a person with low vision pursue MBBS? Can a doctor with blindness, legal blindness, become psychiatrist? Can a blind specialist, of course a doctor, get an employment in a medical college? This is the photograph of Dr. Ruta Nonax. So when she has the lived experience of Stargardt macular degeneration. So when she joined the medical college in the US, the dean asked her, do you plan to complete medical school? And you know, certainly you won't be able to practice medicine. Few years later, Dr. Nonax completed her MD from Cornell University Medical College. She did her PhD from Rockefeller University in New York. She did her residency and fellowship from Mass General Hospital. And currently, she is a psychiatrist at Harvard Medical School with specialization in perinatal and reproductive psychiatry. Another example comes from the Department of Ophthalmology, Johns Hopkins University. I gave you the example of Harvard. Let's go to Johns Hopkins University. Dr. Bonnie Swanner with degenerative retinal disease. She was inspired by her colleague who asked her one question: lead with your science, not your disability. And she published a reflection in JAMA, and the article is titled Losing Vision and Gaining Perspective. And she writes, my career has helped me grieve my lost vision and accept my identity as a person with disability. She is a prominent researcher, and in Lancet last few months ago, she published this paper where she writes that ableism is a formidable threat to health equity. Including people with disabilities in all health equity efforts is the first step, and this work must begin with public health. Let's move from US to UK. UK has admitted the first deaf-blind medical student in the UK. She has both deafness and blindness, dual sensory loss. And she says, I have less eyesight than most, but I have more insight than many. The cover of Indian Journal of Medical Ethics last year showed the photograph of Dr. Zelda Swapnal, who is a dental sedationist. She had retinal detachment in 2017, and she lost retinal again in her good eye in 2019. She have had cataract surgery in both eyes and subsequently developed glaucoma in her bad eye. And she says, with the help of my amazing consultant, ophthalmologist, work team, family, friends, and my fiancé, I can continue working as a dental sedationist and help dental phobic patients achieve their oral health goals. This is the evidence from the global world. Let's come back to India. What is the situation for those with visual disabilities in Indian medical system? So low vision as well as deafness, both of these were specified disability from the 1995 Act, which thereby by law, they should have got reservation for 3% during that act. However, they never got their recognition. The first committee which was created was in 2009 at the erstwhile MCI, and there was a single ophthalmologist, and the declaration was that category 1, 20% and above visual disability shall not be eligible for MBBS. That was 2009. Still, there are many candidates with low vision who was admitted through general category. They had to forego their constitutional right to get reservation because MCI debarred them, but they completed their MBBS through the general category. There are examples within India. In 2018, we had a new landmark Rights of Persons with Disabilities Act 2016, which had now increased the disability from 14 to 21. And as per the NEET form for 2018, as well as MCI's circular, they could apply for the NEET 2018 exam. And thereby, many of these candidates applied, including those with low vision and hearing impairment. After the exam, the guidelines came in 2018, June, 4th of June. And for visual disability, the mandate was that category 3 and above, not eligible. And the justification was that they shall not be able to acquire skills and quote unquote knowledge. That is, people with low vision who had done their MBBS in the general category, they have gained knowledge. But here, this is the statement which was given in the 2018 MCI Gazette guidelines, not Gazette, it was not gazetted guidelines. So there were many people who had to, kill their dream of becoming a doctor with low vision, as well as dyslexia, as well as hearing impairment. There were only a few who had the guts to went to High Court and then to Supreme Court of India. Ashutosh Puriswani had low vision, and he filed this case in the Supreme Court in 2018. And the Supreme Court ordered the All India Institute of Medical Sciences Ophthalmological Board to give they asked two specific questions. Is this person a person with benchmark disability? The answer was yes. The second question, can he do MBBS? The answer was no. However, the apex court was not pleased. And it is mentioned in the judgment that the memo did not disclose the exact reasons for forming the opinion that the petitioner was not fit for the MBBS. And for the very first time in the history in India in medical education, a low vision candidate was granted admission in MBBS in Gujarat. And following that order, there was another case of a girl with hearing impairment in VMMC in Safdarjung, who won the case in Delhi High Court, and she is currently doing, along with Ashutosh Puriswani, MBBS from the medical college. These guidelines were criticized by experts from premier institutions like All India Institute of Medical Sciences, where they have said that arguments against those with disabilities pursuing medicine are prejudiced. And Professor Khan here says that what impedes special people is not their disability, but rather the inability of society to provide opportunities for accessibility and acceptance. Today in the Lancet, there is a report which is being published, and it mentions that the case of a girl who had missing fingers in her non-dominant hand, who has been denied MBBS admission. And with the case is in Supreme Court, and it has reached today's Lancet. These guidelines were also criticized by 75 doctors with disabilities, and we made our representation to the Ministry of Health and Family Welfare as well as the Honorable Supreme Court. And thereby, some of the controversial guidelines were taken off. And thereby, a candidate with dyslexia, there were 8 candidates with dyslexia, they were denied admission in Mumbai. But since there was a case in Delhi, that candidate has joined my medical college, and now he's in the 3rd year of doing MBBS. So the problem is that when others decide, there might be an element of implicit bias or unconscious bias. After this decision of the Supreme Court for the NEET UG, again, the guideline from National Medical Commission now said that all with more than 40% of the visual disabilities were deemed ineligible, which was very surprising because Honorable Supreme Court has allowed Ashutosh Puriswani. And thereby, on 20th January 2019, Ministry of Health did not concur with the ophthalmologic expert of National Medical Commission. And thereby, again, the decision has to be changed regarding the guideline. And thereby, again, the guidelines was revised that those with more than 40% of visual disability can be given benefit if the extent of disability can be brought to another rider less than 40% with advanced low vision aids such as telescope, magnifiers, etc., which is given in the appendix H of the Gazette notification. So again, it has, first of all, it has to be more than 40%. Then it has to be less than 40%. And do we have any scientific basis for that? Why it has to come down to less than 40% again? On 8th March 2019, Ministry of Health objected to the MCI disability regulations for both and UG-PG regulations for visual disability, saying that in visual impairment, the rationale for mentioning categories type 1 to 3 of disabilities specific in visual is not clear, and therefore its defined percentage is unclear, and thereby it was again changed. A day earlier, around 7th of March, the BOG, the group of experts of MCI, they said that a committee should look into the eligibility for the specific post-graduation courses for students with which type of specialization they should opt. Unfortunately, this committee has not yet been constituted. And since there has been two cases, one from Punjab and one from Maharashtra, both MBBS doctors with visual disabilities who have done their MBBS, they're applying for post-graduations in psychiatry, they have been disallowed. So a committee has not been constituted officially by NMC, but separately for these two individual cases, it is under their premise. But All India Institute of Medical Sciences has finally framed guidelines for admission of candidates with disabilities in postgraduate courses at AIIMS Delhi. But again, it has been criticized by many people because what is mentioned is that, for example, the first line, some people may have an erroneous notion that psychiatry is a specialty where candidates who are deaf or have low vision may be considered, but this is not true. And it has been written in bold letters. One must accept the fact that everyone cannot do everything. Now, there has been complaint with the Ministry of Health that this document has been plagiarized with the General Medical Council's welcomed and valued guidelines for undergraduate, postgraduate, and doctors with disabilities in practice. The red lines are, you can see the words which are there in the GMC UK's document. Please pay attention to the last word. On reasonable accommodation, the GMC UK, their National Medical Commission, says that request for adjustment can be declined if it is not reasonable, but it is unlawful not to consider reasonable adjustment at all. A line which has been not mentioned anywhere in the document by the All India Institute of Medical Sciences guidelines. Now, India has a law on disability, 2016 guidelines. Section 3.3 very clearly says that denial of accommodation amounts to discrimination, and thereby under section 89 and 92, it is punishable under the law. Let's see why blind people cannot do psychiatry. Tim Cordes was a legally blind medical student. When he went to the University of Wisconsin, people asked, what are you doing here? He's seen over here with the guide dog, which is Bella, which is named Bella. So Tim Cordes is now a physician at the University of Wisconsin, and he oversees psychiatry interns at two different hospitals. During his medical college, he placed a tube in a patient's windpipe correctly for the very first time. In his third year, he won Student of the Year honors from Obs-Gynae and Anesthesiology department. And with the help of reasonable accommodations, for example, visual describers, he had gone into operation theaters, assisted with the birth of a baby, helped during surgery, and intubated a patient. The chief of psychiatry at this University of Wisconsin Medical College has said, using just his sense of touch, he has discovered potentially life-threatening blood clots that others able-bodied, sighted people had missed. What is the opinion on legally blind psychiatrists? What is the acceptance among healthcare providers, patients, and ophthalmologists? Let's see. Dr. Hartman was the first legally blind psychiatrist in the US. and the annual Southwestern Virginia magazine, in which nurses and other health professionals list their preferred doctors, ranked Dr. Hartman first in psychiatry for 8 consecutive years. The reference is given below. What is the attitude of patients? Patients expressed a preference for a blind psychiatrist and often reported that they felt more comfortable revealing more of themselves when they did not feel watched. Which is a better sense, vision or the absence of vision? The ophthalmologist, the chief of at the Harvard Medical School, Dr. Charles Sheffens, has said about Dr. Hartman, it takes imagination, not a sight, to be a good physician. The National Medical Commission has unfortunately used the guidelines prescribed by Association of American Medical Colleges way back in 1979, which we call as organic technical standards. These were even criticized by AAMC and Academy of Physiatrists in 1993, where they say that where a candidate's ability to quote unquote observe is compromised, there must be alternative means or abilities to acquire and demonstrate that essential skill. India has heralded into an era of competency-based medical education. And the CBME focuses on what students must demonstrate rather than how they must demonstrate it. For example, a medical student with a hand disability, which are not allowed by National Medical Commission at all, may have to examine a patient's ear with the assistance of an intermediary holding an otoscope in place while the student visually examines the ear. The diagnosis is made by the person with a hand disability, not by the intermediary. Similarly, in the Supreme Court of Iowa, there was a case in Palmer College versus Davenport where a legally blind student, he was given radiographs and he said he needs a reasonable accommodation in the form of sighted interpreter so that they can read the findings to the person so that he can arrive at a diagnosis. The college said, no, the presence of quote unquote vision is necessary to perform this function. The case went to Supreme Court of Iowa and the Supreme Court cited a dozen examples of blind medical students successfully graduated from various medical schools in the US. And thereby they held that, you know, the case which was filed by the student is justified and he should be admitted. The Association of Academic Physiatrists, which I mentioned, which has evolved the guidelines over the years in the US, the most developed countries, when they came to know about the guidelines, they have given this thing, a letter to me, which is there in the Delhi High Court, that we were distraught that still in India, individuals with disabilities are being stopped from pursuing a medical education. And they say, we would encourage you to avoid eligibility criteria that relate simply to medical diagnosis and rely instead on assessments of the students' capacities when given reasonable accommodations. The 2018 guide document by the National Medical Commission, the Appendix H, which came in on February 4, 2019, the Appendix H1, which came on May 2019 and Gazette notified, does not provide any way by which reasonable accommodation can be provided and provides a blanket ban on many other type of disabilities apart from visual disabilities. Also, there is a very troubling mention in the 2018 guidelines, which says that some checks and measures to safeguard against the problem of malingering and willful attempt on part of person to gain higher or lower percentage as applicable needs to be evolved and put in place. Now, people with disabilities are already a marginalized community. Here, what is being done is that they are being labeled as cheaters. And this has been countered by the Honorable Supreme Court of India by Justice, no other than Justice D.Y. Chandrachud, the most read person, who has mentioned in Dr. Vikas Kumar versus UPSC in the 2021 Supreme Court case last year that undue suspicion about the disabled engaging in wrongdoing is unwarranted. Such a view presumes persons with disabilities as a class as incompetent and incapable of success. The disabled confront stereotypes in several aspects of their day-to-day lives. One of them is that they do not perform as well as others. Like other stereotypes, this one is also totally flawed and contrary to reality. Such an ableist premise is inconsistent with the approach to disability enshrined in the UNCRPD and the RPDA. The case was that of Dr. Vikas Kumar, who has done MBBS from GS Medical College. He has dysgraphia. But unfortunately, if you look at the NMC guidelines, I mean, even the Supreme Court is unaware that dysgraphia is very selectively barred from becoming a doctor. And we all know that all the doctors have a very poor handwriting. So what are the barriers and enablers? My second last slide. Very often, these opinions are based by a single person from one specialty. And we all are humans. We all may be having our unconscious or conscious biases. What we need is, we need to use the slogan from the disability sector, nothing about us without us. You are making the policies for the disabled students. It is a matter of their education, their life, their ambition. How many doctors with disabilities or health professionals with disabilities are involved in these committees? Why are we trusting that we sighted people are more capable in understanding the journey of those with visual disabilities? How many of us seen a doctor with visual disability, has interacted with them? There are many in India. Ableism undermines access, and that's why the lived experience of disability must be an expertise. We have navigated the system. We know, as a disabled doctor, I can say that I know what are the challenges, how I can navigate them. A non-disabled person cannot even imagine that in his or her wildest imagination. We are still based on medical model of disability. The world has gone past to the human rights model of disability. We still do not know, we are still ignorant about reasonable accommodation. There was somebody posted this, that there was this right to information about that how many students with disabilities are provided reasonable accommodation in a very premier institution. The answer was that this information is available at the hostel section. So their knowledge about reasonable accommodation is only hostel accommodation. There are questions about patient safety, but as Dr. Sinha has said in one of the previous webinars on back to basics, and I like that, it has to be evidence-based advocacy. If there is a threat, please show me the evidence. Is that threat is not there in the United States? Is that not there in the United Kingdom? The threat is only in India. We often assume about disability. There are no guidance. There is a guidance from NMC, but what about reasonable accommodations? Is there any circular from National Medical Commission about we are labeling them as person with disability 5% reservation? How will they navigate their journey in medical school? Where are the reasonable accommodations? Look at the example from the West. The General Medical Council in UK, their guidance is named Welcome and Valued, which is a guideline for learners with disability in undergraduate, postgraduate education, and later on even in practice. The second one came from the American Association of Medical Colleges in 2018, Accessibility, Inclusion, and Action in Medical Education. The third one is the International Council for Disability Inclusion in Medical Education, where we are preparing guidelines as well as the reasonable accommodations, which can be used globally as well as in the countries where no guidance exists. So finally, how does a doctor look like? We need to shun our biases. These all are doctors, medical professionals. They may be blind, but these are working. I gave you examples from the West. In India, Dr. Y.G. Parmeswara shown here. He was the first doctor who did pharmacology, has retired as professor at one of a Bangalore medical college. And that is the reason why the Ministry of Social Justice and Empowerment had Gazette notified the post of pharmacology as deemed identified suitable for somebody with visual disability. The same is there for psychiatry, perhaps which NMCI is not aware of. You are reserving a post identified in employment. And another example is this Dr. Sharath Philip, who has done MD psychiatry from Institution of National Importance, NIMHANS, Bangalore. He has blindness and he has done his MD from there in psychiatry. He has done his 3 years of SRship and further 1 more year over there. He has 4 years of experience post MD with visual disability. And I would like to quote in the end the words of Emeritus Chair of Ophthalmology, Dan Albert, that not only do these gifted disabled physicians benefit medicine, sciences, and their patients, but their classmates learn from them. They gain empathy for people with disabilities and learn a lesson in courage. And in the end, I would like to say that medical profession is not a superhuman profession. What we need is not robots. What we need is empathetic and compassionate physicians. Thank you so much.
Thank you, Professor Singh. That was a wonderful presentation, very informative, some very good examples, and very thought-provoking as well. And
very inspiring.
Very inspiring as well.
Inspiring.
Yeah. And we have received multiple comments as well as questions also, which we will definitely discuss at the end. We would like to have comments from Professor Kamaljeet Singh.
It was a wonderful lecture, and some insights into the disabilities. And I'm really impressed by this talk and giving some examples from the Supreme Court of India. I know Chandrachud, who was justice here also, is a brilliant guy who can take the task properly and can give us lots of opinions. And about this disability, I know one of my friends who got unfortunately accident by a car, and he had lost his right hand, not lost, but it was damaged. So he started operating from the other hand, and he became a very good surgeon with the left hand. So the disability can give you, as Dr. Satinder has already said, that you can improve upon so many things. Like amblyopia can improve, you can improve the disability also, and you can use the other hand, other eye. And I know many ophthalmologists who are color vision defective, and there are many people who have amblyopia also. They are doing very good surgery in ophthalmology, where we always say that stereopsis is required. And with the availability of the screen kind of things that you are having in the AIMS also, the surgery would become much easier, even if you have poor vision and the magnification is very good. So we have to keep on evolving ourselves. And this lecture has really given us a great insight. Thank you so much.
Thank you, sir.
Just a comment. Our own Dr. G. Venkateswamy from Arvind Hospital. He was invalidated from army because of rheumatoid arthritis. He was an OB-GYN person, and he went on to make the world record, Guinness Book of World Records, if I'm not mistaken, for doing the maximum cataract surgeries with his crippled hands. So he was a living example. Dr. GV is a living example of what disability can not stop you. You have to have that determination. Thank you.
Dr. Suresh Advani, who has pioneered India's bone marrow transplant program. He is a wheelchair user, 100% disability, not found suitable as per a National Medical Commission. He was awarded BC Roy Award by the same Medical Council of India. He was awarded Padma Shri by the President of India. He was awarded Padma Vibhushan from India, and he's working in Tata Institute right now.
That's really wonderful. So let's have the last talk, the fourth talk by Dr. Tamil Senthil, who is talking on implementation strategies for visual criteria standards in driving and employment in India.
Yeah, am I audible?
Yes, yes.
Yeah. Thank you, Dr. Rajesh and Dr. Namrata, for inviting me to talk. I think something very different from the regular programs which we always have, and a new subject which is not generally talked in the webinars or conferences. So I thought maybe somebody from the regular clinical practice side and from the entrepreneurial side, more than whatever we talk, I think everything gets into the execution part. So how do we actually execute? So, and I thought maybe my talk should focus more on how do we actually, what are the lacunae in the present system, and how do we go about executing the visual standards, which all the previous speakers were talking about in the past three talks. And thanks for everybody, because I didn't want to have an overlap. So I'm going to talk more about the driving license standards and what is happening and what is happening in the West and how we can improvise that. And I'm sure AOS and All India Institute of Medical Sciences, we can together put it together to the government and do the screening in a far better way. And it's very common that we keep reading in the newspapers that every year we have 5 lakh road traffic accidents, and more than 1.5 to 2 lakh people, they die. And of all the fatal accidents, most of it is attributed to the, at least 80% is attributed to the driver's error. So most of the driver, either they don't have good vision or they don't have hearing function, and all those things which are not properly checked, and these leads to these accidents. And if we start screening people in a better way, I'm sure majority of these accidents could be prevented. Even in the first talk, we were listening that 50% of the drivers, when you go and screen some heavy vehicle drivers, at least 50% of them don't have acceptable level of vision. That was also outlined by the previous speakers. I would like to share something interesting. I did a vision screening for diabetologists for diabetic retinopathy in a conference in Chennai for the diabetes conference. Out of, I think, 200 diabetologists, almost 80 of them had most of them were diabetics. The diabetologists were diabetics, and at least 30-40 of them had retinopathy. They have never checked their retinas before, or every year they don't check. So the lack of awareness even among doctors is very high. So why alone drivers? So drivers are not having the awareness unless there is a mandatory system for screening them. I don't think people will go and get screened. So what is happening in the driving license scenario in India? So this, as like any old rules in India, the Motor Vehicle Act was put forward in 1988, and then it had one single amendment in 2017. And when you go for a regular license, there is a self-declaration form. This is the self-declaration form which you get when you go to get your driving license, where you have to declare yourself that you are able to distinguish with each eye. The 3 questions highlighted in yellow, and it doesn't specify any particular visual acuity test, except that you are able to read with each eye license plate at a distance of 25 meters. And then the color are you able to distinguish, and then if you suffer from night blindness. So you have to give your declaration when you go to the driving license. And I'm sure even if you have these issues, most of us are going to say, I don't have this. And then if it is a transport vehicle, this is also followed by a letter or a certificate which you get from a medical examiner who is generally an MBBS doctor, who will also ask you these same 3 questions if you get to see a medical doctor. But most of the time what happens is, if you go through a driving school, they have their own doctors who will actually put the stick, they don't even see you, and they just give you that you have answered all these questions and that he has checked you. So most of the people who actually get the licenses don't get any kind of vision screening. I think with India progressing and with so many amount of vehicles on the roads, and I'm sure these old rules have to be definitely changed. And this is not the way we have to get the vision screened for our people, if you're really caring about people who are driving on the roads, because it's not only the driver who is going to get affected, but it is also the common public who might get affected because of these improper kind of system which we still have in place all over India. So let's see what are the international standards. International Council of Ophthalmology has a better way of evaluating vision for driving, whether they say visual acuity as B20/40 are better, and also a visual field assessment 120-degree horizontal and 40-degree vertical. So visual acuity and visual field, I think maybe this can be a slightly better standard than what we are having in India. So what are all the visual assessments which we can do when somebody goes for a driving license or an employment screening? Is visual acuity, visual fields, and then maybe color vision, or visual fields only, or visual acuity only, or a license plate self-test as it is projected in India. So what is Europe doing? So most of the European countries, if you see, they have visual acuity, visual fields. And many of them have a visual acuity and visual fields only, and very few of them have only the visual acuity, but a very small number has this kind of a license plate self-testing thing. So most standards would be to have visual acuity assessment, visual field assessment. I think both, and the color vision together. I think that should form a regular thing for a driving license as in the Europe. So the next question is, who is supposed to test the visual acuity? Is it somebody who is a medical doctor or an ophthalmologist or an optometrist, or any of the employee in the motor vehicle department. So who is testing? So let's see what happens in the Europe. So basically most of the countries, it's the medical doctor who does the testing. I think in India also, we have the medical doctor to test the visual acuity or who has to do the testing, but only issue is happens in the execution part, because the medical doctors don't get to see the people, and because of the lacking in system, people don't get to see the medical doctor before they get certified that their vision is right to get the visual license, driving license. Ophthalmologists would be better, but maybe with huge population in India, I don't know how many ophthalmologists will be able to check or assess for a regular driving license test, or an optometrist or an optician. So majority of the countries, medical doctor is the norm, MBBS doctor who can do the visual acuity assessment. So what happens in the US? So America has a very good system. Basically what they have done is, all the motor vehicle departments, they have people who will test the visual acuity. There are two ways you can get your vision tested. One is you go to the driving motor vehicle department to get your license. So they are equipped with the vision screener equipment, which can test all the criteria like visual acuity, the color vision, and field of vision. Or they have also created a network of registry, a network of vision authorized vision screening centers, which can be a pharmacy, which can be an optical shop, which can be an ophthalmology clinic or a general hospital, which can screen people for vision, and they have a software where the authorized agency can upload the visual screening test, and with that test you go to the driving license to get your license. So they have kind of decentralized the process of visual acuity and visual screening. So I think this can be a good model for India, where we can actually propose to the government to outsource this, just like we have these pollution testing centers. When we go to test the vehicle pollution, you have this authorized emission testing centers. So why not authorized vision screening centers, which can actually screen people for the vision before they go to a driving test. So there are only two strategies, I think, which will definitely work. One is equip all these RTO offices with a simple vision screener kind of an equipment. So this equipment is not very expensive. I think even in America, it's something like 2 to 3 lakh rupees, or maybe Indian companies can make it still at a cheaper cost, where this equipment will screen for most of the disabilities, including the visual acuity, the color vision, and the field of vision. And then if you get a pass, then you are qualified to get a license. So that is something which I think we should also try to implement or propose to the government. I have always thought, in fact, I have approached a few of the governments also, if they would be interested to implement a vision screening tool in the RTO offices, in the regional transport offices, where people can get screened. But as you know, maybe the proposal has to go from a national body, and maybe if we can implement it in a few states, I think it can become a national kind of a model to screen people. The other model is, along with this, we can actually create these authorized vision screening centers for driving license, which can be an optometrist or an ophthalmologist, and they will have. Now the website of the Motor Vehicle Authority of India, the Parivahan, is a very good website. You have a lot of online details. You don't have to, you can see the data of your vehicle, and you can even download your RC book, everything online. So easily it could be connected with all these vision screening centers to implement a uniform standardized vision screening program pan-India. So this is what is the roadmap? I think I've already discussed about this. So first thing is to standardize the visual acuity assessment method. So what is the visual acuity? I think definitely we should move from this 25 meter, if you can read a number plate kind of a model, to visual acuity testing, either a Snellen's chart, and then how do you actually screen for the field of vision, and then color vision, whether it's Ishihara. So standardize the assessment modality, and then equip the RTO offices, and then also start these vision screening centers all over India. I think that is something which can really change the way people are screening and then getting the driving licenses. And I'm sure the number of fatalities, which is at 1,50,000, 2 lakh every year, will definitely reduce by at least 50% if we are able to create this kind of a system. The other thing is encourage more research in assessment tools for measurement of visual functions. And also, I think more important for associations like All India Ophthalmology Society or the ophthalmologist is to improve the awareness of public, because only if the public understand that they have to, it's very risky for them to drive with poor vision, then they are going to get their vision tested. I think it's important to also create this public awareness. Mandatory thing is one part, but also on the other hand, creating good public awareness to get their vision screened for fitness to drive. That is something very important. And then we should propose for new amendments to this Motor Vehicle Act. I don't know when it is going to come, but maybe we should also, there are many countries which have restricted visual performance standards. Like maybe you can, one thing is, as we also discussed initially about testing these drivers regularly, like at least once in 2 years, 3 years, because I think right now somebody gets a license, it's for 5 years or 7 years, so you don't have to get tested in between. So somebody driving a heavy vehicle, I think you should have regular testing, and then if somebody is over the age of 65 years, have a strict model of screening for those people. And there are also legislations which allow people to have a restricted kind of a license. For example, somebody can drive only in the daytime if he has some defect in night vision, or somebody who can drive only within 10 kilometers of their periphery of their home. So these kind of restricted licensing methodology can also be proposed to be included in the amendment if at all it comes in the future. So the conclusion is to standardize the screening criteria for driving license. I didn't talk much about employment because of lack of time, but I think even for employment, because there is a different kind of requirement for different jobs, but maybe the screening criteria, the procedure to screen can be standardized. And as I said, equip the RTO offices with the equipments and vision screening people, and utilize the services of ophthalmologists and optometrists, because right now I don't see ophthalmologists having a large role in screening for regular driving licenses. So utilize and involve ophthalmologists more in the driving license, vision screening for driving license. And people who fail in the initial screening should undergo a protocol-based evaluation by an ophthalmologist. And every driver who has been involved in a fatal accident should ideally have his visual functions reassessed by an ophthalmologist. I think right now even that kind of a system is not yet existing. And implement very good visual screening protocols for employment, and standardized protocol for employment, particularly in, say, right now, I think we have good criteria for railways or army, but we don't have good criteria for other jobs. So basic kind of screening protocols for employment, which shall have good vision criteria. So I think we have to create those screening protocols also. So I would like to thank Dr. Santosh Honavar for his article. I have taken a few of the points from his article, which is quite interesting, and I would like to acknowledge him for that information. And so these are my contact information, and hope we will all join together, and I think we can definitely create a change and represent to the government, and create when this amendment comes, I think we should really push for that. Or we can even approach the state governments and then start implementing those standards, which can penetrate into the central government. Thank you.
Thank you, Dr. Senthil. It was once again a very good talk, and some very good points. The point that you mentioned that, people should have periodic checkups, and something like, pollution certificate. Somebody should be carrying a certificate indicating that he's not suffering from visual disability. That's really wonderful. Would like to have comments from Dr. B.N.R. Subudhi. Sir, please.
Thank you, Professor Rajesh, Professor Namrata, Professor Titial, and my esteemed colleagues. Thank you for giving an opportunity to speak something in this webinar, very unusual webinar, I would say. I think I learned a lot from the topics already discussed. I compliment all the speakers. They've done the job wonderfully. Thank you, Dr. Senthil, giving the wide, elaborate picture of what the status of driving license in our country. Quoting same thing from Dr. Santosh Sanavat's article, I would like to say that over 80% of road accidents are due to driver error, mostly in ghats. Many times, in our country, a lot of ghat roads were very unsafe. The slightest error on the part of the driver leads to so many casualties, including death. And as already Dr. Chandana has already said, many times we are surprised to see when we examine the people, drivers during the tests, majority of people are having at least 50% or less than that about the vision. Maybe a refractive error, maybe a cataract, maybe diabetic retinopathy. So these are the issues are sometimes neglected in our driving tests. So always when we are asked to give a certificate, we examine the only visual acuity a little bit, not very much strict about that. But besides visual acuity, I think other things like our contrast sensitivity, color vision, and the visual fields, night vision, glare disability, all has to be taken into account. But sometimes we don't give much importance while giving a certificate, medical certificate for the driving license. And of course, as Dr. Senthil already told, that the vision criteria for the driving license varies from country to country. Many times we get a license here, but our license is not accepted in other countries where we have to undergo again stringent tests. Again, the driving a private vehicle and driving a commercial vehicle, the criteria are different, and some commercial vehicles there should be mandatory for the stricter vision tests. As already told that our driving license issued by the regional transport officer and from each state, and they vary from state to state, but however they follow the Motor Vehicle Act of 1988, which has been revised in 2017. Sometimes while renewal of the driving license also you become a little bit reluctant, or sometimes we give a leniency on while renewal of license, because once the license is issued, this license is issued for the 5 years. In this 5 years, the person might have suffered some disease, but person might have developed some refractive errors, which has not been taken into account. Once the license is given for 5 years, he drives irrespective of his disability. So there are a lot of lacunae, and we must take into account of this lacunae. We must have a standardized protocol, based on the ICO protocol, where we should have a guideline for all the states, one common guideline. Again, sometimes whenever we find a road accident, very minor road accidents, we don't take into account of the license of the driver. Just give a few punishments, we leave them. But are we examining these people, those who have got even trivial accidents also, whether they have driving capability, driving license? We don't check. Just give a, sometimes in our country, everything is possible, just pay some money. So even in the sometime back, 5 years back or 7 years back, whether no digital was available, and we used to get the license sitting at home also. So these to be again amended, and this to be brought into the common platform, and whether All India Ophthalmology Society can do something for this, and all the All India Ophthalmology Society stalwarts are here. Can we form a guideline like some other diseases? We've done infection control, we've done SICS, we've done so many things. Can we form a guideline for all the ophthalmologists in our country to follow a guideline so that we can give a safe driving license to our who apply for the driving license? So these are some issues. We have to sit with the government also and make a common guideline. So I think Dr. Senthil has covered everything, and almost we covered everything. So now I request our Secretary, All India Ophthalmology Society, and also Professor and the Chief of AIMS to come forward to make some common guideline. So thank you very much for giving an opportunity to speak a few lines on this.
Thank you, sir. And we have many comments and questions, but we'll just take a few of them because of paucity of time. And we'll request one of the speakers or the panelists to comment on these queries. That there is a question from Dr. Anupama, who wants to know that if a patient comes with low vision, what is the cutoff point for giving a disability certificate? That is Dr. Anupama Bishwas. So, ma'am, Dr. Kierti Singh, can you take up this?
I think Dr. Radhika covered it really very well.
Yeah. Ma'am is there? Radhika, ma'am?
There is a chart available
Okay.
there.
So, yeah,
She
so
really
it's
covered it
basically,
well.
yeah, she covered it very well.
Yeah, so but
Obviously, 618,
618
less than 618 in better eye, and less than 660 is disability. Yeah.
In the better eye. In the
The
better
better
eye,
eye.
618 is low
Yeah.
vision again, but
Yeah.
the chart says about vision of 6.9 with the visual field less than 10 degrees. So it's not
Yeah.
only low vision as per the vision acuity for distance, it's also the visual field. However, one big problem with low vision is that near vision is not taken into account, which is the only one which is really treatable. But the guidelines say it's 618 and one-eyed status is 30%. But if it's a visual field also involved, then it ranges from 75 to 100%, with even if the 6/6 vision is there. So that NPCB chart will tell you very clearly which one is disabled. And for school admissions and for college admission, not for school, for college admissions, there's a entry criteria for visually disabled. And for that, you need 40%. And one-eyed with 30% sometimes do not qualify for that. So you need to look into that also.
There's a question for you, ma'am.
What I was trying to say was that there is no need to remember all these criteria. You should have a chart with you.
It's there.
Like today, there is no need of remembering the periodic table that we used to Rato. When we were students. So you have everything in your hand, then you can take the chart.
Yeah. There's a question for you, ma'am, that if all color defective candidates are to be cleared, this is by Dr. Manisha, if all color defective candidates are to be cleared in their medical board exam, what's the need to check it at all?
See, there are two aspects. One is cleared in which exam? She hasn't clarified, undergraduate or postgraduate. What my talk was that in undergraduate, we are screening, we are clearing them for undergraduate entrance, but we are not clearing them for postgraduate, some specialties. Now, there is definitely a need for screening because screening tells you what problem you have. It is not a disability as I clarified, but it's a problem. And you can, once you know about your problem, you can go about rectifying it. Ignorance is never bliss. Ignorance is just thought to be bliss. It's never bliss. So screening is very important. And most of the candidates who had this CVD were very requiring screening, and they were very emphatic that yes, screening has helped us. Second is if everybody has to be cleared. Again, if everybody has to be cleared, which most of the Western countries, which most of the other countries, not Western, are doing, there is still a need because it tells you what all lacking you have, and especially if you want to specialize in a field where it may cause you a constant handicap. Like if you have a red protanopia and you want to go in for microbiology, you are going to have problems. If you're going to go into dermatology, you're going to have problems. So might as well choose a field where you will not have this burden. I would not say handicap. You don't have this burden. You can fly high, but screening 100% it should be there.
Yeah. Dr. Taswala says that I am on the expert committee of Supreme Court for making guidelines for Film Institute student admission. So to give a go ahead to give green signal to color vision defectives.
Film industry?
Yeah.
I think how will it make
how will it affect them? I mean, as long as you say a red sari is a red sari and a green and a green eyeliner is a green eyeliner, how would it make a difference to the actors?
Yeah. True.
It shouldn't make a difference to them.
Yeah. Dr. Gurvinder Kaur says that I feel the doctors with disabilities must be included in the panel which decides guidelines for admission for these people, and this is what Dr. Satinder was also telling, and I mean, one may consider that.
That's the slogan of Disability Commission, nothing about us without us.
Yeah. And then she also says that if a person completes MBBS and gets disabled later, they need to be included in the medical profession. So that's something which then then there are some repetitions, and then some lot of appreciations for one wonderful presentation by Radhika ma'am, wonderful presentation by on color vision by Kierti ma'am. Then of course a couple of
you can just call the do a roll call for the audience. Give them
a lot of appreciations for the driving thing that Dr. Senthil also told, and Dr. Satinder also was had some very good examples by Dr. Satinder. So there are a lot of appreciations have come, and they have thanked all the speakers. So any comment from any of the panelists or any of the speakers?
Thank you, Dr. Rajesh, for choosing this wonderful topic.
Very wonderful.
Really enjoyed and learned a lot.
Yes.
I have a suggestion, Dr. Rajesh.
Ma'am.
If we could all compile all this into a text so that all the people can learn from it, and I would be happy to have it in the next video
I
issue.
have a suggestion, Dr. Namrata. I think we should make a guideline. We should make a committee and formulate a guideline and print a book.
That's what I'm saying.
I think that is a suggestion really well taken. And Dr. Chityal sir, who is also the advisor to the Government of India, is very much here. And I think we can take it up, Rajesh, at the All India Ophthalmological Society platform and do a focus group meeting on it. I think it is a very vital and important subject, and come out with a written text so that, it clarifies, and we would require everybody's help who've been a part of such a successful, webinar. And again, thanks, Rajesh, for choosing such a wonderful topic, which actually did not look very interesting in the beginning, frankly, because it looked like we are, going to, but it really came out really very well.
Yeah, and I guess it needs more discussion than what we had.
Rajesh, I think in future we can have debate on some of these topics.
Really. And Dr. Satinder Singh, I think I must really congratulate you for that excellent talk, which, was so gripping that even for a second we could not move off it.
Yeah.
It was like a story.
It was like a story. That's what Kamaljeet sir has mentioned. And yes, it was.
And we didn't know so many things, about our own ophthalmologists, which you highlighted.
See, I've been lucky to know Dr. Satinder for the last 5 years, and he has much more things up his sleeve than he's coming up with. He's a champion of disability because he's gone through some disabilities himself, and it's an amazing journey he has been through. Salutes to him.
So it was really, I had to think a lot in selecting, the speakers and the panelists, because I wanted to know who all are experienced in this field. And I was definitely knowing about Radhika ma'am because she is, of course, my teacher, but the ma'am also. But then I got to know about Dr. Senthil also, that he is into it. So yes, it took some time.
Who is very much into it.
Yeah.
But one suggestion I have, I have dealt with disabilities also as a warden and as a provost. It's easy to say get into MBBS. Dr. Satinder, I would a little bit differ with you, because it's easy to say when they are gutsy, they can do it. But when they come into a college where the lift is not working, where they have to climb 3 floors, where some things are not available all the time, it's not disabled friendly, despite our having ramps, despite our having other things, especially the physically disabled, it's not very easy coping up. So in not just the guidelines need to change, the mindset of the teachers and the administrators of colleges need to change, that if disabled, or as you call them in Hindi, Divyangs are in whichever form, then we also have to, make our vision into a Divya vision and start thinking like that and start. I'll give a small example. When I was in UK, we had this Alsatian dogs who would be there, the walkers with the visually handicapped people, and the other people would stop and they would permit the dog to go through. In India, you can't even think of that happening. People would just shove you. So those criteria, those children have a double disadvantage. One, they have disabilities. Second, the infrastructure and the mindset of the people is not very welcoming. That needs to change also, other than the guidelines.
Yeah. Can I make one comment before we close? I think rather than waiting for the government to do those changes, what we can do is, as ophthalmologists, we can create these, because most of our camps are focused on, say, cataracts and other things. Maybe we can also involve with this local drivers associations and screen the lorry drivers, because I think even if there is no mandatory rule to screen them, maybe if we can create a screening program where say each of us associate with the driving school or a lorry drivers association kind of a thing and screen the drivers, I think that would be a great service. Another thing, I've seen many of the eye hospitals themselves, they are not friendly for the blind people. Just like even our lift, maybe some of the lifts have those braille kind of thing, which even visually impaired people can access the floors. Only a few companies have that, but I have not seen that in many of the eye hospitals. So maybe we should build our eye hospitals disabled friendly. Even blind people can access our hospitals in easier way. I think we can start off with things which we can implement on our own, and then slowly push the changes to the government. Because I personally have tried to approach the RTO, the local RTO in my area, the road transport officer, and I said, sir, if you want, we will screen the people who come for the driving license free of cost. But only thing, because of those administrative thing, he was not able to do that, though he was in favor of that idea. So we said, we will do it for free. Only thing, you send all those people who come for driving license to our center, then we will screen them and give you the report. Only thing, he was having the governmental difficulty, because that is not permitted to do that. So, but I think we can start those implementation from ourselves. Say if each of the eye hospitals can screen 100 drivers in a day, I think definitely in a month, in a year, I think we can reach out to a lot of drivers, and we can create those changes which we want to change on our own, and then push to the government to implement those changes. I think that can be a better solution.
So that's wonderful, and we received wonderful inputs from everyone. So concluding remarks from Professor Tital, sir.
Yeah, thank you, Rajesh. Wonderful presentation and discussions. I think as Dr. Subhuti rightly pointed out, maybe our AIOS should form a focus group, work on this, and we can fulfill the desire of Kierti to have a booklet coming out, and that can be circulated to all the people, not only our area but other common work of people where they decide on our disability areas also, because public has to be aware on these points also. So maybe I think good point to have a one focus group, have a meetings, formulate the positive guidelines. Maybe that will open the eyes of people who make rules and regulations.
Yes.
And we know that rightly pointed out, disability will definitely open the other sensory areas to be better than what you have lost. That we have seen for many people, and it's absolutely true. And sometimes people with a visual impairment may have a better vision than people who have a good vision. So that's a good point. I think we should support that. I'm fully for that.
Yes.
And I think the discussions as far as concerned, like the time frame may not permit the actual debate which was a thought of, but debate will never solve the problem in these type of cases. It has to be discussed in a full length with each point of each profession, each requirement, each level of disability engagement into the professional work. That has to be taken out. I think it was a very good initiative, Rajesh. Maybe future also, you can have people from the Ministry of Social Justice, if possible.
Yeah.
And second, I thought maybe we could have had a person from Railways, because they have absolutely a very strict, public, you can say, apart from the armed forces, Railway is another area where the medical board is very, very strong.
Yeah.
Because armed forces people are totally different. They don't come into our category of examinations. But yes, it was a very good initiative. Thank you, all the speakers and discussion. It was terrific.
Thank you, sir.
Thank you,
So
sir.
in the end, I would like to thank all the speakers, ma'am, Kierti ma'am, Dr. Senthil, Professor Satinder Singh, all the esteemed panelists, Professor Sulata, Professor Chandna Chakravarti, Professor Kamaljeet Singh, sir, Professor Buddhi, sir, and of course, I would like to thank our staff, Dr. Anil Kumar, Mr. Anil, and the IT team led by Bageshwar, and of course, support by IPCA and their IT team. So thank you very much. Thanks to all.
Thank you. Thanks to all.
And a very good night to all of you.
Good night. Thank you. Thank you.
Thank you. Take care.